But welcome everyone to our CTSA Irving Institute Implementation Science Seminar for today. Rachel Shelton, I'm Sapana Patel, Rachel Shelton, myself, and Natalie Moyse, who is here with us as well, are very happy to host this seminar every month. I'm going to introduce our speakers. So we are very lucky today to have Dr. Melinda Davis join us. Dr. Davis is professor in the Department of Family Medicine at the Oregon Health and Science University, PSU, School of Public Health, and director of the Oregon Rural Practice-Based Research Network, and also the Oregon Clinical and Translational Research Institute and Community Collaboration Core at OHSU. Dr. Davis is a participatory implementation scientist who collaborates with patient, community, and health system partners to adapt and implement interventions to improve health equity in rural and low-resourced settings. So we are very lucky to have Dr. Davis. And with that introduction, I'll turn it over to you.
Thank you, Sapana. I'm excited to be here today. I want to thank all of you for making time. I know we're in this we're post-pandemic, but I'm noticing kind of a pendulum swing where people are still tired and trying to figure out how to recover and balance their time. So here's my outline for today. And I was saying to Sapana, I have a lot I want to share, but I'll do my best to stay on time and give us some time at the end for discussion. But I just want to start with some light introductions to understand both what my orientation is, but who you guys are. I'm going to highlight the labs in which I work and partner, because I think in terms of lessons learned, one of the things I'll emphasize is that aligning with existing infrastructure and building on that infrastructure is a really powerful way to sustain partnership and really have an impact in your work. I'll highlight, if there's time, one article that explores kind of this blend of quality improvement and implementation science within practice-based research networks, and give an example in our Smarter CRC, NCI-funded National Cancer Moonshot Initiative. So it's a lot, but we'll see how it goes, and we can kind of guide that discussion based on the dynamics today. So as Sapana mentioned, I am a professor at Oregon Health and Sciences University, but I think relevant to this and my work is that I grew up in a rural community and actually just recently moved back out from the metro area to a rural community. So it's I think a really exciting time and silver lining of the pandemic that we can work a little more remotely and be with the communities we hope to serve. And over the last 2 decades, I've really done a lot of my work within one practice-based research network that I'll share about, the Oregon Rural Practice-Based Research Network, as well as a community academic collaboration called the Community Health Advocacy and Research Alliance, or CHARA. And CHARA is one of our regional CTSA community hubs. And so I'll tie that into the broader structure of our CTSA community program. So this is a lessons learned talk. I thought it's always nice to sometimes start with some kind of personal lessons learned. And these are some of the, I think, insights from mentors and colleagues that have been really helpful as I advance in my academic career. One of them, the first from a close colleague, a primary care clinician who's now the medical director for the Federal Office of Rural Health Policy. But Kristen Dillon says, you know, we judge our insides against other people's outsides. And hopefully, as we do introductions in the chat in just a bit, I think especially as you're early on in your career, you can have a lot of questions about how will I get there? How did that happen? And I think it's really important to remember, you know, what we're aware of in ourselves is not always what we're seeing in others. And others are often dealing with various challenges and uncertainties as well. So it's important just to remember. Kurt Stange has said a career only looks linear in reverse. I'll show a little bit about mine because we can tell these really beautiful arcing stories, but there's often a lot of nuance underneath the surface. And then in academia, I think we all need some different tricks and tools to keep us kind of persevering given the funding and hit rate. And I think Chris Latour said this really powerful thing is, you know, write the grant the first time to get the pieces together and then revise and get it in the second time to get it funded. So I think just kind of changing the rules sometimes to align with what the actual context is can really be helpful. The other thing too is early in my career, as I was starting to build out my academic community partnership, I was presenting for one of our research meetings, and a very seasoned faculty member said, you know, do you actually want to do research or do you want to do good? And at the time, I think I had, you know, a response that highlighted how I was using rigor and complexity in my work. But over time, I think what I've realized is this is not a polarity. This is a both and that there's a real opportunity to think about how do you do good by doing good research. And I think many of us who work with CTSAs or with practices or with communities, we're really motivated by this desire to do research as a form of service and to really know what works most effectively in our communities or settings. If you're like me, I think you're probably pretty aware of the gap between our research and a lot of the clinical care that's happening in our practices and community settings. And that's really, I think, the beauty of both PBRNs and the CTSA infrastructure is they're really designed to help speed and bridge that gap. And Sapana, I think you had mentioned this in the chat, but one of the things that I think is maybe a challenge often with implementation science in academia is that we often are socialized to have expertise in a specific intervention. And I think if you're oriented to do community-based work, I think it's really important to be thinking about an assessment of the context and the local dynamics and thinking about within this specific setting, what's the right intervention that we should be implementing. So I think there's sometimes an opportunity to think not so much about what's the tool or approach where I have expertise, but really, am I the right partner for the setting, given their kind of current needs and pressures? And I think, you know, we can have a philosophical discussion, but the pathway in academia can often lead you to specialize. And then after you specialize, I think, again, there are opportunities to diversify and become more service-oriented and responsive, but there can often be a little tension point as you're developing. So this should be easy. I saw many people are from rural communities or work in rural. So in the chat, would you tell me what for you defines rural? How do we think about rural? I think there are lots of experts that, because you're thinking about the real true definitions, you're probably defining them for me now, but feel free to put in the chat, what defines rural for you? How do you think about rural? Yeah, low population density. Yes, space from an urban center or commuting, and then some of the differences in characteristics around resources, poverty, inequities that might exist in rural spaces. Yeah, geographically dispersed care, so long travel distances and access to care. The population census housing, community and proximity, open spaces. Yeah, you guys are hitting all the nails on the head. This is a really wonderful article by Gary Hart and colleagues if you're not familiar with it. But what it highlights is that there are multiple different definitions for rural. They're generally oriented around focusing on population size, commuting patterns, proximity to urban centers. But what's really interesting is that the definitions that are applied for different policies or even in our research can have really profound implications for access to resources. And there's been, I think, quite a bit of work at a national level to try to come up with some harmony among our rural definitions, but there's also been a lot of challenges in doing that. And one of the resources that I love letting people know about is this rural health information hub tool, where you can put in any zip code or address, and it'll tell you how does that location define on various definitions of rural, and then which different programs are they eligible for based on that definition. So when you're working with communities, this can be a really helpful resource for understanding, like, do they qualify, particularly if you're looking at specific mechanisms or funding opportunities. The other thing you guys may be aware of is that there's quite a disparity between kind of the population distribution in rural areas and the kind of attention for funding work in these populations. So in the map here, you can see in the kind of light green to red, most of the Western states, about 97% of the land mass in the US is actually defined as rural. But there was a really interesting article by leaders at the National Cancer Institute in 2017, which said that only 3% of their R-level research funding was actually focused on rural settings. And so there's been quite a few different RFAs that have come up in the past 5 or 6 years, trying to really emphasize a focus on rural and addressing rural inequities. And I think Oregon, like many of our rural states, is a really good kind of system or setting or microcosm for exploring some of these differences within rural or opportunities to address inequities in rural. And what you'll see here and throughout this presentation, I'll have a lot of maps of Oregon, but this is basically a map of Oregon, and you can see the Portland metro areas here. And the I-5 corridor, this is where most of our urban centers are located in the red. We have the Cascade Mountains that kind of come down right here, just a little east of the I-5 corridor. And then the eastern side of the state tends to be high desert farming country, so much more dispersed and agricultural than I think we often think of the forested kind of aspects of Oregon. What you also see here, this is the Oregon Office of Rural Health definition of rural, is that all the green is rural space. And so the darker green is actually frontier communities. And so those are regions that often have a population of less than 6 people per square mile. So as you guys were highlighting in the definitions, like really sparse populations, open space. The other thing just to note on this slide is that there are various inequities or disparities related to income, education, and unemployment within rural settings. And I think the patterns in Oregon are pretty similar to many of the patterns across the country, although other parts of the country may have more extremes. And so this is my quiz. So if Manhattan were frontier, how many people would live in the city? You're welcome to put it in the chat. If you're really excited, you can come off mute and shout it out so you can be the first to potentially win the prize. So 6 people per square mile for a frontier community. Less than 100. In the Price is Right rules, you're winning right now. 150. Let's do it. Sapana, you did some quick math, or you're a math whiz, but yeah, about 150 folks. So Manhattan, the island, is about there's about 1.6 million folks total when I looked at the Wikipedia census information, and that's about 72,000 people per square mile. So quite a big difference to think about what Manhattan would be if it was defined as frontier, as I just showed in the last slide, which is about 10 of our 36 counties in Oregon, or a majority of the state. So what I want to highlight now are just some of the infrastructure that we've built in Oregon to have capacity and connections across the state. I think the other thing that's interesting about Oregon, I didn't mention it, but Oregon, kind of like New York, is big. So basically from Portland out to the Idaho border is probably a 6-hour drive. From Portland down to the California border is about a 6-hour drive. So it's a pretty big swath of land. And one of the networks, this is the network that I've worked with since 2007. I actually started as a regionally based practice facilitator out here in Northeast Oregon while I was finishing my PhD. And ORPRN is a network. It was started by a rural primary care doc who moved to OHSU. He had been part of the National Ambulatory Sentinel Practice Network when he was practicing down in Reedsport, Oregon on the coast. And when he moved to the metro area, he really thought, you know, this is an opportunity to have a practice-based research network, which is really founded on addressing rural clinician and practice needs. And the network has really evolved over the past 2 decades, where we now work with urban and suburban clinics. We have not just research initiatives, but we have an education core that does ECHO network programming across the state, and then a policy team that does a lot of work working with our state public health department and the Medicaid transformation initiatives to kind of translate policies into how they can get applied into practice. And we also work kind of interestingly, and this is where there's increasing synergies with our CTSA, is beyond the boundaries of primary care. So I think we've seen in a lot of our PBRN programs and evolution to really recognizing that health is not just limited to that clinical encounter, but there's so much outside of the clinical encounter that's critical too. And Dr. Fagnan, who was the ORPRN director, this was a really early article that highlighted the important role that PBRNs can play in terms of bridging from bedside into practice. And they can do that through, various types of studies, including implementing, dissemination, and implementation research, or the other term, translational science studies. And you may be familiar with the work by Care White or Larry Green, but it really talks about the ecology of care and makes the case for why studies in primary care settings are so critical. In that report, they talk about how in any population of, say, 1,000, about 800 might report symptoms in any given month. Of those, about 600 will seek care. 200 will seek care, and about 113 will seek care in a primary care office, but less than 1 will actually be admitted to an academic health center like OHSU. And so it's really critical for us to be thinking about how do we do data collection with those populations that are most likely to be in need for care. The other thing that I think is really relevant is that, that means 600 people are presenting with some type of symptom, but not seeking care anywhere. And so again, that makes the case for just continuing to move beyond the walls of our healthcare settings to think about how do we address healthcare needs or advance equity. The other thing just to emphasize about PBRNs is that they, similar to I think a lot of our community engaged work, are really focused on maintaining connections beyond individual projects, right? And so not just swooping in and disappearing, but really having a backbone structure so that you can maintain relationship and also build capacity of network members over time. The other thing I think that's been really interesting within the PBRN world is just that many of the studies have gotten more complex with time. So when I started, we often did, chart audits or observational studies, or they used to do these card studies where people would have a little 3x5 card in their pocket to document kind of basic delivery of care. And over time, we've really expanded to doing larger pragmatic trials. We do a lot of work to link clinics with community-based resources. And then, as I mentioned, our health policy team does a lot of work around operationalizing policy and practice. And ORPRN, this is just, visually helpful. When I started, again, we were a very small team, and we've grown to about 60 folks serving across the state in multiple capacities. If you're interested in learning more, we did put out our first impact report in 2023 that just highlights the breadth of work we do and the various sources of funding and impacts that we have. So one of the things that makes this successful is the regional team, and ORPRN is really anchored in a team of practice facilitators across the state. Sapana mentioned the CERC, and one of the things we do in ORPRN is we also lead the International Conference on Practice Facilitation. And I think for years we've been trying to model after CERC because they've been so successful in transitioning from initially a conference to now a national society. But practice facilitation is one kind of implementation strategy, which is often called a meta implementation strategy, but it's basically an individual who brings skills in organizational development, project management, quality improvement, and they can help kind of bridge between the research and the actual implementation on the ground. And it's been a really, I think, effective mechanism. We often say, facilitation can lower the activation energy for change. So the other lab that I want to just highlight is academic community collaboration called the CHARA, the Community Health Advocacy and Research Alliance. And I mentioned how Kristen Dillon, she was one of our clinical partners in ORPRN since I started, and we were attending the North American Primary Care Research Group meeting, and she said, we've done all this really great work in clinical settings, but we're doing a lot of community-wide health system transformation. And I don't know how often we're looking at what are the effective interventions or even evaluating what we're doing here. wouldn't it be great if we could apply some of what we've done in the PBRN world to our community-based work? And so shortly after that conference, PCORI actually came out with their pipeline to proposal award funding mechanism, which was really around building academic community collaborations, specifically around comparative effectiveness research, but really to address the priorities of patient and community partners. And so we were able to build this network, and we did a number of community engagement activities, including a retreat where we identified kind of 3 priority areas for CHARA to address. One around lifestyle interventions, so diet, physical activity, social determinants of health. One around mental health and substance misuse, and one around addressing the Medicaid state level clinical quality indicators. And these are things at the time which were like colorectal cancer screening and immunization rates and depression screening. They evolve annually, but many of them stay consistent over time. And as I continue to tell my story, part of what I'll highlight is I ended up focusing on colorectal cancer because of work of this community group. And basically, the community had tried to move the metric for colorectal cancer. They hadn't had the impact they wanted. And so Coco Yackley at the time said, Melinda, can you look at the research literature and help us figure out what should we be doing here? And so it's been a really interesting system for thinking about participatory implementation science and partnered implementation over time. The other thing I'll just highlight is that CHARA is actually located here in the Columbia Gorge. This is also the area where I grew up, but it's one of 7 of our regions which are served by regional community research liaisons, who the research liaisons, similar to the practice facilitators, are really meant to build relationships with communities over time and really help to identify what our community needs, to build capacity in communities, and to make sure we're doing, appropriately partnered work. The other thing, and it sounds like you might have something like this at Columbia, but I'm actually really proud of this structure, because one of the things we've built over the last 3 to 5 years is actually an umbrella organization that brings many of our community-focused programs together, so that when we get requests for support from academic partners or for community partners, we have a process now where we review these requests weekly and we think about, is this opportunity the best for our Knight Cancer Institute Community Outreach Engagement Core? Is it best for the PBRN? Or does it live in the Clinical and Translational Research Institute with our community program or our evaluation core? And it's just been a really nice opportunity to shift away from, I think, what used to happen where folks might approach individual programs and kind of try to figure out what's the best deal, to now being like, oh, this is wonderful. We'll have a transparent conversation and really figure out who's the right partner to move this work forward. I think it really helps center our communities too, because it helps not just build collaboration between our programs, but make sure the communities are getting the best support. And so this is a very busy map that just shows you all of the regional folks that are present across the state and kind of their outreach. We've also been really working to build regional relationships and capacity across those teams over time. So maybe a comic to drive this home. In academia, it's easy for us to get isolated and forget what it's actually like out there. And so having these partners who are based in our communities can really help kind of keep us honest, keep us anchored. We have 2 articles that were published in the past that highlight relationships between PBRNs and CTSAs. I think there's a group within the CTSA D&I working group that's in the process of getting ready to repeat this survey. And so hopefully there'll be an opportunity to really understand how have these relationships evolved over time. This is really relevant to some of the efforts happening on a national level, where the National Institute of Health is starting to explore if they can start funding and building capacity to speed the translation of research into practice by funding existing primary care networks. And I think, Sapana, when we were emailing, I just emphasized I was part of a recent panel, which was highlighting what some of the opportunities are to leverage this existing structure. And so I wanted to give 2 scenarios, because I think the scenarios can help us think about how things can go well in partnered research or how they might be challenging. So in this first scenario, it says a seasoned researcher seeks to enhance diversity in their pragmatic clinical trial. They start cold calling federally qualified health centers across the state. After 6 months, they enroll one clinic. After 12 months, over 200 patients have been eligible for the study, but only 5 were recruited. Moreover, the researcher is not able to access data from the EHR on these patients. The clinic medical director is frustrated and advocates to avoid studies with the researcher's institution in the future. So I don't know if you've been in situations like this, but this was drawn from prior experiences that I've seen. I think one of the main things to emphasize is, that challenges like this don't just affect individual researchers, they can have ripple effects for a whole program or institution. In scenario 2, which is the more ideal situation, is the same researcher has a new idea. They now realize working with community clinics is outside their expertise. They present their idea at the CTSA's design studio and are referred to a PBRN. The PBRN team helps them refine the study design, data collection strategies, clinic impact fees, and transitions participant recruitment to both visit-based and population outreach strategies. The researcher adds the PBRN director as a study MPI and funds regional staff. Based on input from the PBRN's advisory board, they align outcomes with a state quality incentive metric. Using PBRN data, the team identifies and approaches 4 clinics. Within 1 month, the same FQHC agrees to participate. Within 3 months, PBRN staff are embedded in the clinic, supporting participant enrollment and data collection activities in alignment with clinic workflows. The PBRN team also has helped refine EHR documentation and reporting to support process and outcomes collection. Within 9 months, the participant recruitment target has been met and diversity criteria exceeded. This has all been achieved despite transitions in the medical director and multiple clinic staff. The project is celebrated by FQHC leadership, who are eager to partner on the next study. So I think just, in anchoring this work, there's a lot of benefit in aligning with existing infrastructure and building on that expertise within our communities across the state. All right. So why does this matter? And how do PBRNs kind of bridge this gap? So one of the things that I noticed is when I started working within PBRNs, it was almost an assumption that we were blending research and practice. A lot of the articles in the PBRN community, they just really emphasize that there is a strong connection between quality improvement cycles. You can see here in this learning evaluation article that within one organization, you may have multiple quality improvement cycles. This was actually an integrated care study. It was focused on improving screening and intervention for folks with behavioral health needs. And that part of the evaluation then is looking across those settings to see what are kind of commonalities or adaptations or changes, or what are the supportive strategies that are needed. And as I started to get more exposure to implementation science, including participating in the mentor training and dissemination and implementation research in cancer, I was really struck by some of the ways that quality improvement was kind of seen as outside of that space. And so we had the opportunity to write a few commentaries that highlight the potential synergies and alignment of these two concepts for supporting change. We also did a study that was published, I think this was published in 2001 or 2002, but it was basically a review of the studies we had done in ORPRN to try to understand which of the projects were implementation science, which were QI, and which were a blend of those projects over time. And when there was a blend of projects, what types of change strategies or what differences were present, like what distinguished these different types of studies. So we looked at data from 2007 to about 2019, and we included 26 studies. A number of studies were excluded because we didn't have full access to the data in our files, or because they were not necessarily implementation science. So a number were kind of qualitative preliminary work. What we found is that they're just in general, the projects averaged 4 years and were funded by a number of agencies. The projects got more complex over time. I don't know if you're experiencing this in your own work, but we used to have a number of light studies, which were things like chart audits or observational work. And a lot of the projects in ORPRN started to be more complex in terms of initiating practice change in some way. So really requiring behavioral change by the clinical team or shifts in workflows. All of the projects, whether they were QI, implementation science, or a blend, used evidence-based interventions. And about half of the projects that were classified as implementation science or a blend use randomized designs, where none of our QI projects did. The other just maybe interesting thing is that for implementation studies, you can see here in this column, they tended to use education and training predominantly as a strategy for supporting change. Whereas for our QI or QI implementation studies, they tend to focus on using practice facilitation as well as education and different concepts. We use the term practice change strategy rather than implementation strategy because as we were looking at the way interventions were delivered, it was often a bundle of approaches as opposed to an individual granular approach, which at the time is what the ERIC strategies really defined and talked about, or individual supportive strategies. The main takeaway from this is again that many characteristics of the implementation science QI or blended studies were similar. It was actually quite hard to distinguish between the types of studies. There were some shifts in terminology, but there were a lot of parallels in the concept. The other thing we talked about is that maybe we shouldn't exclude or have excluded some of the studies that were not initially classified as implementation science QI or blended, because those qualitative or process-oriented studies can really set a robust foundation for future work and may actually be critical for support of future implementation science projects. The other thing we did is we developed this image, which really just highlights the complementary aspects of implementation science and QI. So with implementation science, we get resources about theories and information on evidence-based programs and systematic processes for improving our implementation. But QI really helps move that kind of, type 1 knowledge, if you've read Thinking Fast and Slow, into that applied knowledge that can be actually integrated into practices in real time. And then you get another circle where implementation science allows you to put on that meta evaluation hat to really figure out what works here and why, and how can we learn generalizable opportunities from these settings. I want to just highlight one kind of final project, and this is just as I mentioned, I was going to talk a little bit about my own trajectory as a way to talk about development over time. This is a beautiful article that just highlights what participatory implementation science is, which is really blending some of the principles from participatory research with the rigor of implementation science. And what participatory implementation science can really help us do is think about centering the context again of really what is the intervention that needs to be implemented in this setting, aligning our methods to site needs, and then building kind of the capacity of sites over time. Rural areas experience a number of cancer disparities. As I mentioned, I ended up focusing on colorectal cancer, but there are really important disparities in terms of lung, colorectal, and cervical. Some of the work we're doing right now is trying to bundle some of our outreach interventions as opposed to focus on individual factors. It's also a really interesting opportunity to look at multi-level factors in your implementation, including how do we attend to individual organizational and policy factors. This article here by Janice Prost, if you're not familiar with it, I really love it. It's an article that highlights kind of how structural urbanism can contribute to poorer health outcomes. And what it really just highlights is that there tends to be a bias toward larger population centers. in part because of kind of a market orientation that requires us to have a critical mass in order to be able to support and fund services. Because with public health, we're often looking at bigger numbers, bigger impact, which can kind of sway us toward looking at larger urban centers. And then finally, just this realization that there are any inefficiencies in rural settings because of lower population densities and longer travel times. And so it's a really, I think, interesting way to think about some of the structural factors and how that can contribute to inequities in rural areas and how we can potentially approach those in our work. So I mentioned, a career only looks linear in reverse, but when you look at my work in colorectal cancer, it looks very sequential. So I started doing work with community engagement with the CHARA coalition around topic selection. We did a really interesting project that was designed by the community partners called Finding the Right Fit. This was actually a study of 6 different fecal immunochemical tests in the community. Because of the 6 clinics in this rural region, they all used a different fecal immunochemical test. And the community partners said, there's no evidence of patient preferences toward these testing. And it would be wonderful if we could actually advocate for one test across our community. We then did some work with workflow analyses and looking at claims to look at regional variation as well as differences in different population groups. We were able to do a systematic review to help think about what's the best intervention for working with rural and lower income populations to improve colorectal cancer screening. We did a pilot, which was with 3 clinics in the Gorge area, looking at mailed fit implementation. And then over the last 4 years, we've been implementing a large moonshot initiative, which is using mailed fit and patient navigation. First in partnership with about 30 clinics in rural Oregon, but then we've been finishing a scale-up study which uses the Extension for Community Health Outcomes, or ELCO approach, to actually engage with health systems nationally to implement these programs. So that looks very linear. This is another way to look at a career pathway, right? Which is, there were lots of things going on. The blue is mostly my colorectal cancer screening work, but you can see there was other cancer activities. I have a behavioral health line, and then we have some work related to access to care. So I think, a key message is it's okay to have a diverse portfolio, and it's really important to just be persistent as you advance your work in this space. So I'm going to jump through a few slides, but what I love about this work is that it was really driven by patient and community preferences. When we had our first retreat to think about ways to approach this issue in 2015, one of our patients said, I've never heard of fecal testing. Doctors should tell you this. Maybe if they had, my brother wouldn't have died from colon cancer. Even one of our rural diabetes educators, she wasn't aware that there were options besides colonoscopy. She said, what? There's an option besides colonoscopy? I want to poop on that card. I want to fit. I can't believe my doctor never told me about this. And so we did a lot of really cool studies to set the stage for this work. And one of them really focused on some of the issues. So as I mentioned, colorectal cancer was a state Medicaid quality incentive metric. We found that our Medicaid health plans were working with clinics, and there were really these kind of 3 key factors. The need for producing and sharing performance data for these relationships to work well, a quality improvement process and infrastructure, and then relationships and partnerships. But we also found that while these approaches were successful, they led to this unintended consequence of focusing on larger clinics, because you in some ways could game the system and meet the targets by working with those larger practices, not necessarily with all the clinics in a community. And so that led us to really think about, how do we make sure we're bridging the gap? As one of our urban primary care practice managers said, no patient should be not screened for colorectal cancer because of the practice they attend. So we did a KO7. I know somebody's on a K23. So hopefully you are getting some really powerful pilot data to set you up for success. And then we were able to partner with Kaiser, with Gloria Coronado, to leverage that work from the pilot to implement a very large scale trial through the Cancer Moonshot Initiative. And just briefly, what we did in this work is we adapted some of the mailed fit materials for work in rural settings. We also modified our navigator training program, which had been developed in Connecticut, based in an urban setting, into to work in rural environments. We did a 2-arm kind of pragmatic implementation trial with 28 of our primary care practices clustered within 3 of our regional health plans. And then we just finished up our spread trial and are analyzing data from that now. So we worked with partners across the state to implement. One of the things, we have a paper that just highlights the challenges. If you've worked in the space, you know how hard it is to get data out of electronic health record systems. And this work was happening during COVID. And so a lot of the normal staffing challenges we see were amplified at this time. But we did see program effectiveness, and we also learned a lot. The navigation was really interesting. We can talk more about that, but basically, in a lot of these sites, they're so small, there was only maybe 1 or 2 folks who were eligible for navigation after an abnormal fit, and it became really hard to implement that dispersed model into care. So these are my, I guess, more collaboration lessons learned insights that I want to emphasize at the conclusion of this talk. And that's really understanding the lay of the land matters. This takes time and local presence and connection. But I'd also say it doesn't necessarily have to be you. Part of the reason I wanted to emphasize those existing structures in Oregon is because I think many of our CTSA programs or our cancer institutes or even practice-based research networks, they have an existing infrastructure. They have a lot of trust that hopefully you can potentially build on and leverage. I think another thing is, if you're drawn to this work because you want to address community needs, there can be an interesting tension as you advance as an academic. And that's, again, this need to focus potentially on a topic to show that you are expert. But I just want to say, recognize that after you focus and demonstrate, there will be opportunities to expand. I think I'm definitely seeing that as I now step into my role as director for our PBRN as well as for our CTSA community program. And I think part of what you can do is help make connections to others so you can still be of service, even if you're not necessarily the one who's offering support. The other thing is just this recognition of balancing research and action. Like a bank account, make sure you're making deposits before you make withdrawals in these settings. And then I think, like I mentioned with ORPRN, it's important to diversify your portfolio. So we are no longer just a research institution. We do education, we do health policy, in part because those 2 lines of work can be a lot more flexible and responsive because they're not necessarily so tied to the funding timeline that many of us experience with research. And then again, I think there's encouragement that leadership opportunities can allow you to build something that lasts beyond you and can help kind of bridge that impact over time. So this is an article I'd encourage you to check out, which highlights, if when you're thinking about working in rural spaces, what are some principles you might apply in terms of using existing data, prioritizing efforts to evaluate, adapt, and expand EBIs in these rural settings, thinking about rural definitions and what the implications of those might be, as well as this interaction of geography with individual and regional factors, and then using this equity-based implementation science approach. So thank you guys so much.
Thank you, Melinda. That was a fantastic talk.